Genetic technologies are rapidly evolving and expanding. As a result, more and more healthcare professionals are faced with treating patients with clinically significant inherited cancer syndromes. The purpose of this video is to explain the cancer risks and management recommendations for patients who test positive for BRCA1, BRCA2, or the Lynch syndrome. As you know, BRCA and Lynch syndrome are the most common inherited cancer syndromes. An understanding of the associated types of cancer risks, the surveillance implication, and the management options will greatly impact the survival for these patients and their families. Dr. Theodora Ross will first talk about BRCA, followed by Dr. Christian Mayorga, who will talk about the Lynch syndrome.
Well, given the greater awareness of genetics and genome sequencing and the cheapness of the test, patients are now coming and saying, hey, should I get a genetic test to tell me whether or not I have an increased risk for cancer? The genes we're talking about are BRCA1, BRCA2, and other genes, PALB2, ATM, etc. Some patients are savvier than others and will ask about the multiple genes. Some will only ask about BRCA1. Some will just say the BRCA. Some will say BRCA2 and BRCA1. And the risk associated with BRCA1 has been estimated in the past as high as 87% lifetime risk for breast cancer. Those risks are now lower, as is the case for BRCA2. The risk for other genes is less specific. BRCA1 and BRCA2 patients carry 40 to 65% lifetime risks for breast cancer. Those with BRCA2 mutations are at the lower end of these ranges, or 40%, and those with BRCA1 at the higher end, or 65%. BRCA1 mutation carriers also have a higher risk for ovarian cancer in the range of 20 to 40% risk over their lifetime. Likewise, BRCA2 risks tend to fall at the lower end of these ranges, or 20%, and BRCA1 at the higher end, or 40%. Patients without mutations have a 1 to 2% lifetime risk for ovarian cancer. BRCA1 and BRCA2 mutations are associated with other cancers as well. BRCA1 and BRCA2 carriers have elevated risk for several types of cancer, including male breast, pancreas, prostate, melanoma, and other cancers. In 2014, the NCCN, or National Comprehensive Cancer Network, came out with new guidelines for testing patients for BRCA1 or BRCA2 mutations. The new guidelines included testing patients who had family histories of prostate and pancreatic cancer and not necessarily breast and ovarian cancer. So patients who have a specific type of breast cancer, the type that doesn't have estrogen receptor, progesterone receptor, or HER2 on the tumor cells, triple negative breast cancers, qualify also for BRCA1 mutation testing. Now, let's talk about the NCCN management guidelines. Overall, high-risk surveillance or a discussion of prophylactic surgery should be initiated by age 25. Specifically, at age 25, initiate clinical breast exams, an annual breast MRI with contrast. Discussion of chemoprevention is recommended for those undergoing high-risk surveillance. Then, at age 30, add mammography annually. Mammography is generally not recommended before age 30. As you can see, when this study compared specificity of 4 methods for breast cancer surveillance to catch early cancers in BRCA mutation carriers, mammogram alone was 36% specific versus the combination of imaging methods that increased it to as high as 95%. Additionally, prophylactic bilateral mastectomy reduces risk by at least 90%. Surveillance screening for ovarian cancer to detect it early is not currently recommended. We have tests, CA125, transvaginal ultrasound, but they are not sufficiently sensitive or specific to detect ovarian cancer and therefore are not standard of care. For patients with BRCA1 mutations, at age 35 to 40 or after childbearing is complete, bilateral salpingo-oophorectomy to reduce risk of ovarian and fallopian tube cancers by at least 80% is recommended. To detect occult ovarian cancer, we add pathologic testing of tissue post-surgery via serial sectioning and peritoneal washing at the time of surgery to screen for occult cancer cells. For patients with BRCA2 mutations, patients can consider delaying bilateral salpingo-oophorectomy until age 40 to 45. This is because BRCA2 mutation-associated ovarian cancers tend to occur later than BRCA1 mutation-associated cancers. Fallopian and ovarian cancers associated with BRCA mutations frequently originate in the fallopian tubes. As a result of that, many centers are initiating studies to remove just the fallopian tubes and leave in the ovaries to prevent premature menopause. However, leaving the ovaries intact is not standard of care and is not recommended by the NCCN at this time. It's worth emphasizing that removing the ovaries and fallopian tubes in BRCA1 and BRCA2 mutation carriers does reduce their risk for ovarian cancer by 80 to 90%. For men, a clinical breast exam is recommended starting at age 35 annually, as there are limited data for imaging recommendations. For prostate cancer, BRCA1 mutation-positive men can consider starting screening by age 45. But for BRCA2 mutation-positive men, the recommendation is to initiate prostate screening at age 45. Of note, some men diagnosed with metastatic prostate cancer who carry BRCA mutations may be eligible for studies using olaparib, a PARP inhibitor. For pancreatic cancer and melanoma risk associated with these mutations, the NCCN has no specific guidelines and does not recommend routine screening. However, we urge you to ask your patients for their family history, and then with the mutations that they carry and their family history, patients are urged to discuss their risk with their families, bring that back to you so that you can tailor their risk management with not only their mutation, but also their family of origin. And finally, what do we recommend for family members of patients who are BRCA mutation carriers? First-degree relatives such as siblings, children, or parents have a 50% risk for this mutation and are recommended for single-site testing. Cousins and other relatives are also recommended. Knowledge of family member mutation status will help define cancer risks and guide medical management recommendations for affected relatives. This is recommended for family members 18 years and older. Well, it's important to urge your patients to continue to update their family history, to explain to them that a genetic test is only one part of the process, that this is not an event, but it's a continuous evaluation that can change over time. If they have family history changes, it'll change their risk and may even change their genetic testing, even if they've already been tested for BRCA1 and BRCA2 and came up with a positive test.
Similar to BRCA-related cancer risk elevation, Lynch syndrome can also significantly increase the risk of developing certain types of cancer. Lynch syndrome is caused by mutations in one of 5 genes: MLH1, MSH2, MSH6, PMS2, and EpCAM, a promoter of MSH2. Lynch syndrome cancer risks primarily include colorectal and endometrial cancers. These risk levels differ by gene. Other cancer risks, which also vary by gene, include gastric, ovarian, hepatobiliary tract, urinary tract, small bowel, in particular duodenum, the central nervous system, particularly the brain, pancreas, and sebaceous neoplasms. The average age of onset of cancer can vary depending on the gene affected. For instance, MLH1 and MSH2 related colon and endometrial cancers tend to have an earlier onset when compared to their MSH6, PMS2 counterparts. This isn't a rule, however. Regarding management recommendations, it's important to note that now all Lynch gene mutations subscribe to the same recommendations. This is in contrast to NCCN 2015 and prior years, where management recommendations varied depending on the gene in question. Colorectal exams should start at age 20 to 25 and repeat every 1 to 2 years, and earlier if family history dictates. Data suggests that aspirin therapy may decrease the risk of colon cancer in Lynch syndrome, but optimal dose and duration are not yet understood. Starting at the age of 25 to 30, you should consider annual physical and neurologic exam. This is according to the Congress of Neurological Surgeons. At age 30 to 35, for urothelial cancer risk, you should consider urinalysis annually. Also at age 30 to 35, certain families or those of Asian descent should consider upper endoscopy with extended duodenoscopy every 3 to 5 years for gastric small bowel cancer risks. Consider testing and treating for H. pylori infections in these patients. For endometrial and ovarian cancer risk, prophylactic hysterectomy and bilateral salpingo-oophorectomy should be considered after childbearing. Endometrial and ovarian screening can be considered at the discretion of the clinician, but it is not endorsed by NCCN guidelines because there is no data to support as sensitivity and specificity are lacking. Currently, there are no screening recommendations for pancreatic cancer, despite the fact that we know that there's an increased risk of developing this cancer in patients with Lynch syndrome. And this has to do with the fact that we currently don't have adequate screening techniques available to us. As far as breast cancer goes, there is some data suggesting that there may be an increased risk of developing breast cancer in certain women with Lynch syndrome. However, the evidence is currently insufficient to recommend increased breast cancer screening in these patients, unless, of course, their family history dictates otherwise. As for family risk, close relatives such as siblings and children or parents have a 50% risk for the identified Lynch syndrome mutation and are recommended for single-site testing. Knowledge of family member mutation status will help define cancer risks and guide medical management recommendations for affected relatives. This is recommended for family members 18 years and older. When two people carry a mutation in the same Lynch syndrome gene, their offspring have a 25% risk to be affected by constitutional mismatch repair deficiency, or CMMRD. Given that Lynch syndrome affects 1 in 300 people in the population, it's important to counsel your Lynch syndrome patients about this possibility. Affected children have cafe au lait spots, early onset Lynch syndrome cancers, and hematological cancers. Family history should be updated annually. This is because the addition of new cancers in a family can have an impact on medical management recommendations, as well as testing options for newer genes, given the possibility of multiple hereditary cancer predisposition syndromes.
Thanks to you both. More than 100 genes are involved in cancer inheritance, and the number is growing annually. Please feel free to contact Dr. Ross or Dr. Mayorga if you have any questions. Also, please visit our provider webpage or call our cancer genetics team at 214-645-2563.